The cannulation usually can be done using various devices like sphincterotomes, simple cannula, pure wire-guided cannulation. The way my first attempt is, if I'm doing a pure biliary case, is use a pure wire-guided cannulation. There are different types of wires that can be used, straight wire and the loop tip wire, which we'll be discussing in this DVD, using a sphincterotome by injecting contrast into the duct and see which duct we are in, which is the standard way. We sometimes do face difficult situations in which our standard technique is that if we repeatedly get into the pancreatic duct, we pass a wire into the pancreatic duct and then try to feel our way over the septum into the bile duct. If all these things fail, standard needle knife pre-cut papillotomy can be used. I would say these are the main tricks that we try. Pure wire-guided cannulation technique has become more prominent, or more physicians or more endoscopists are using it in the last couple of years. Lots of studies have shown that injecting contrast into the pancreatic duct does increase the risk of post-ERCP pancreatitis. The advantage of pure wire-guided cannulation that you can visualize the duct which is accessed just on fluoroscopy by the way or the direction in which the guide wire has gone. And we don't really need to inject inside the pancreatic duct or in the bile duct to know where we are. I think that is one of the reasons why physicians are using more and more wire-guided cannulation technique. One other reason for that will be, in the past, all the devices that were being used were long wire devices where the nurse assisting the procedure or the assistant is passing the guide wire into the duct. With the newly available physician-controlled systems, the physician has control over the guide wire, which makes or helps the physician to have a feel in passage of the wire. In pure wire-guided cannulation technique, there are some key elements that we need to remember. One, we have to have a perfect orientation so that the wire is being pointed towards the bile duct. And remember our basic biliary anatomy, in which the bile duct runs in a cephalad direction around 10 to 11 o'clock position. Also, we have to have an adequate visualization of the papilla so we know where the wire is hitting at the papillary orifice. There are different wires which people have been using for pure wire-guided cannulation. The straight tip hydrophilic wire, the newly available Fusion LoopTip wire. With a pure hydrophilic wire, the disadvantage is that the wire can cause submucosal dissections without realizing if the tissue is soft. After that, when you try to inject, you can get a submucosal edema and a bleb formation. Also, if the wire repeatedly goes into the pancreatic duct, it can perforate the side branches or even at the level of genu. The advantage of the loop tip wire, because of an atraumatic loop, the wire, if it is hitting a fold, a valve, or goes into the pancreatic duct, it does not cause too much of trauma.